So how many of you have been through dementia training before? Okay, put your hand down. Okay. So really it feels a little more contrived because I'm back here. Normally, it's really because we're going to tape the presentations for future training, but really want to keep it pretty informal. I want you to stop me whenever you need to. Let's talk about the situations, talk about the information. The first hour is pretty more didactic, giving you kind of the basics. Since we have an eclectic group of folks here, some of you maybe have worked with dementia residents before, some of you maybe have had some training. For some of you, this could be brand spanking new. So if you already have some of this information, sit back and consider it a review. For those of you who it's brand spanking new, slow me down if you need to. Really want to get through most of the clinical basic information. Then we're going to talk about how do you apply this in some of the case materials, okay? So before I go any further, let me introduce myself and then you can tell me who you are. My name is Dr. Stevic-Rust. I am a clinical health psychologist. I've been working in the field of dementia care for the better part of 20-some plus years. So tell me who you are and what you do here at the facility.
I am Willis Sparks, and I work over in the AL unit, the memory care, and the housekeeping.
Okay, first, second, what shift? Because shift matters.
First and second.
Okay.
Regina Mesa, I work in the assisted living memory care.
First shift as a nurse.
As a nurse, yes.
Okay.
Debbie Sims, I'm a nurse over 36 years, but I'm right now a student being mentored by corporate director of quality here.
Okay, very good. And in the nursing role, did you do work on a memory care unit or?
I've only in home health, I've done pediatric rehab and labor and delivery, that type of thing, emergency room, but mainly my dementia cases were home health.
Okay.
Catherine Glenn, rehab nurse, the Wiles, second shift.
Okay.
Shamika Ward, SPNA, home care.
Marissa Gallender, volunteer coordinator.
Okay, very good. I talk about shift matters because as we get into this, and those of you who had some clinical experience, you know that this population changes not only hour by hour, but certainly by the time of day. And so what our second shift staff might see versus our night shift versus our first shift can be very different. Certainly also on a rehab unit, just because somebody is coming in for a broken hip doesn't mean that they check their dementia at the door. So you could be on a rehab unit and still have a dementia experience. And the same thing holds true, I think, maybe not so much in labor and delivery, but definitely on some of our acute intensive care units as well. Okay, so what I want to do is to start the slides. Oh, goodness. All right. So I'd like to start off first to get a good overview here. We're going to do a basic quiz. So the very first question, memory loss is a normal part of aging. How many say true? Okay. How many say false? Okay. How many are just not sure? Okay. So if you said true, it's probably because you're like me and you're over 50, and we think it's got to be true, right? Because we can't remember things. So the answer is really false, and it's a little bit of a trick question because this is the way we think about memory loss. As we age, the brain does something called atrophy, so it shrinks, and things sag. Just like our bodies, our brain does the same. And with that means we lose our ability to multitask in the same way that we could in our 20s and maybe even parts of our 30s. You know yourself as you age, you're thinking, what did I come up here for? Or where did I put that? Or, ooh, I forgot to do that. Or you look at somebody and you're thinking, I know their name as much as I know my own, but do you think I can come up with it? Which then can sometimes be alarming, like, oh my gosh, what's the matter with me? So it's important that we think about those kinds of changes as really being a normal part of aging. It takes us a little longer. We maybe have to do more lists. If we're distracted, we're unlikely to get back to where we were as quickly as we did in our 20s. But true memory loss is a medical term that really refers to losing information in a 30-second to a 2-minute window of time. So when we talk about memory loss, we're talking about really, we're going to give somebody information, and in 30 seconds or a couple minutes, they're going to look at you as if, I don't even know that you gave me information. As opposed to, ooh, I can't quite remember that, but give me a minute. So the answer is actually false. So when, and why I think this is a really important place for us to start is oftentimes you're going to be exposed to family members or even other healthcare providers who will say to you, she's 83, so she's a little forgetful. It's a normal part of aging, which just really doesn't settle for those of us who are in memory care, because the answer is it's not a normal part of aging. If they're really truly forgetting in the way that we describe memory loss, then something is going on clinically and they deserve a medical workup. How many times does somebody who's a little confused and somebody looks at their chart and goes, oh, well, they're in their 80s, they're confused, they must have dementia. And again, as we go through the slides here, you're going to really appreciate that there's many more things that can be contributing to short-term memory loss and confusion, and all of our seniors deserve a good, thorough assessment before a diagnosis is made. Okay, now I'm going to get into some of the nitty-gritty, and I don't expect you to know this. It's kind of a primer for what we're going to talk about. So the next question is, vascular dementia is progressive with an insidious onset. And remember that insidious means we can't quite pinpoint exactly when it started. So the answer is true or false? Got a couple of trues. True. Another true. Okay. As we get through this, you're going to see the answer is actually false. What type of disease actually has a progressive and an insidious onset is Alzheimer's disease. And we'll talk about the distinction between the two, but there is a very distinct pathology that occurs between those two disease states, and how they progress is a little bit different. Okay, how many know about a mini mental status exam? How many have ever heard of that? Okay, so a mini mental status exam, usually the ones that we use, is called a Folstein. It's a score of 30, so perfect score is 30 out of 30. It would ask for things like short-term memory. We're quizzing them. We're looking at their ability to spatially orient designs. We're asking questions to check their concentration and their attention. That score then gives you an assessment of approximately where the person might be at in their thinking. So my question is, a mini mental status exam score can be helpful in establishing a treatment plan. True or false? And I'm going to also tell you this is a trick question. You're going to say true?
False.
False?
False.
False? The answer is false. And here's why. And I put this up here because I see clinicians doing this all the time. And at the end of our presentation today, I want you to have a better thought process about that, even if you're not actually the one doing the mental status exams. So let's say, for example, somebody scores 12 out of 30, which is really pretty poor, and somebody scores 18 out of 30. How will you as the care provider interpret that number into a treatment plan? So for example, would the 12 out of 30 need medication? With the 18 out of 30, we would expect that they could toilet themselves more safely. You know, we make all kinds of assumptions in a treatment plan based on sometimes a number. And my argument is that test is really designed to put you in the ballpark. It's just a screening test as to how much they're having trouble, what their deficits are, what the level is. So certainly, if you look at a piece of paper and you see somebody with a 27 out of 30 versus somebody with a 12 out of 30, you're going to say, wow, there's a big difference. And there probably is. But it should only be there in place to talk about diagnoses and the assessment process, but not about a treatment plan. A treatment plan should be guided really from a much different place, and we're going to talk a little bit about that, okay? Now, how many of you have heard the word anticholinesterase medications? One of them is actually called, the trade name is Aricept. And so my question is, and again, it's an interesting one, but anticholinesterase medications such as Aricept are used to calm patients with dementia. True or false? So we have a mixed bag, and the answer is it's a mixed answer. If we had been doing this talk about 2 years ago, the answer would have been false, because Aricept and Namenda are really drugs that were designed for the sole purpose of trying to slow down the damage that occurs in the brain. So hence the name anti-Alzheimer's, even though it's not really anti-anything, it's just changing how quickly the neurons are destroyed, was their sole purpose. But in the last year and a half, new studies have come out to show that Aricept, as a medication all by itself, can have anti-anxiety properties for residents. That's brand spanking new. So I would really not expect any of you to know that today because it's not really even been put into clinical practice. But I think it's relevant for you to understand because what happens usually with families? They'll come to you and they'll say, you know that medicine, they're not any better. I don't want them to take that anymore. So first of all, we have to do some education that they're not going to get better. This medicine was never designed to make them better. It was designed to slow down the progression so their quality of life could be at its peak. But now we can make the argument that even when we're not sure it's helping cognitively, that there is an added benefit to say it may actually be helping with some of the anxiety and the agitation that gets worse as the disease progresses. So there's another added benefit. All right, patients with Alzheimer's disease rarely experience major depression. True or false? 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 Correct. The answer is false. Just like we know that with this disease, it damages the cognitive areas of the brain, meaning we know that people will struggle with short-term memory, logic, reasoning, attention, and concentration. What else does the brain do? It regulates our mood. It addresses our personality. So certainly if a disease is damaging the brain, we would expect that it could interfere with the ability to regulate depression, anxiety. So they are often found pretty close together as conditions. Two more quick questions here. Alzheimer's disease causes loss in short-term memory, but does not change the person's personality. True or false? False. And that would be correct, false. For the very reason that I talked about, sometimes we can have families very painfully say, that's just not my dad. He was such a quiet, private man, and now he's publicly masturbating or he's spitting on people or things that you think, my God, that's just not who he was. We definitely know that particularly when the frontal lobe of the brain is affected, you're going to see changes in personality. And lastly, infections and metabolic changes do not affect the mental status of a person who already has memory loss due to Alzheimer's disease. So infections like a UTI or changes in blood counts is really what the question is asking. So true or false? False. And that's correct. You and I could get the flu tomorrow, and we have healthy functioning brains. We're going to feel crummy, but it's not going to change our thinking. You give a person who already has diseased brain, it's exquisitely sensitive to any changes. The flu, pneumonia, a UTI. So when you see patients who you say, boy, there was a big change from yesterday to today, we know that the disease doesn't typically act like that. So the most important thing then from a nursing perspective is to start raising a flag to say, this is not the same person. So we can start looking for, is there an infection? Is there something else going on that we're starting to see what we call a delirium on top of that dementia? Okay. If you're not with me, raise your hand. Is everybody following? Yes.
What else could cause those drastic changes other than infection?
Small strokes, anything metabolic, so like electrolytes that are unstable, sodium, potassium, so if somebody's a bit dehydrated and the sodium potassium is at a disequilibrium, again, an exquisitely sensitive brain would respond to that. Certainly if somebody has an infection anyplace. Those would be the primary that you would see a more acute, quick change. Loss of blood. Okay. So let's talk a little bit about, if there's nothing else you take away from what I say today, this is it. So are you ready? You hanging on my every word here? All right. Anytime somebody says to you, does my loved one have dementia or Alzheimer's disease? It is the wrong question, okay? Dementia is not a disease. Dementia is a description. So all dementia means is the person has cognitive difficulties, problem solving, impaired reasoning, impaired logic, short-term memory difficulties, language disturbances, any of those things. It's like saying you have a headache. All right, we know what that means. You've got pain and it's in the head area. But then the next question is, what's causing it? So we've got dementia, check. Yes, they have dementia. Now, what is the cause of that condition? And there are over 100 different kinds of diseases that causes dementia. So that's a lot. The good news is I'm not going to talk about all 100 today. Say, oh. Do I have a Okay. What we are going to talk about is really what I think of as the top 4, or at least 4 of them that we should be paying attention to. Okay? So number 1, we're going to certainly spend some time talking about Alzheimer's disease. So the question isn't, does my mom have Alzheimer's or dementia? The question is, does my mom have dementia? And then the question is, what's causing it? Okay? Everybody's with me on that. Then the second thing we're going to spend some time talking about is a condition called vascular disease or vascular dementia. In the old days, we used to refer to this as multi-infarct dementia, because essentially what would happen is if somebody's had a series of strokes, we could look at their CAT scan and we could see lesions throughout the brain or multiple infarcts that we know was really leading and causing them to have the difficulties that they do. The third is something called Lewy body. How many of you are familiar with Lewy body dementia? Okay, and we're going to spend a little bit of time talking about that. The prevalency rates for Lewy body seems to be increasing, and behaviorally, when we spend some time talking about it, you're going to see it's a very difficult disease to manage. And so I think it's important for us in this conversation to talk a little bit more about that. And lastly, the other area I want to spend some time on is something called frontal lobe dementia. And frontal lobe dementia, or temporal frontal lobe dementia, they're really still not sure because it kind of sits in the cusp of both areas of the brain, has been getting a lot more press in the more recent years, because of the conversation and the attention we're giving to concussions and post-concussion syndromes. So I'm going to spend a little bit of time talking about that. Now let me add that certainly, again, this is not an exhaustive list. There is something called Korsakoff dementia that we tend to see in our alcoholics. So important that you're getting a good clinical history. You know, somebody comes in and they've been a drinker all of their life. They're starting to have some difficulties. We tend to start thinking about Korsakoff type dementia. There's also something called Huntington's disease, which causes dementia, and it's a inherited neuromuscular disease as well. So I'm throwing those out there. Parkinson's disease. You can have dementia related to Parkinson's condition as well. But for the purposes of our talk here today, I'm going to focus on those 4. And since I'm the presenter, I get to choose which 4 we're going to talk about. All right. So Alzheimer's disease, we know, is the most common form of dementia. In the quiz, when I talked about the insidious onset, this is one of those where you could probably ask a family, when did you notice your dad was starting to have some trouble? And if you get an answer that sounds something like this, well, you know what, about a year ago, we were at a family reunion. We kind of thought Dad was repeating his stories and didn't seem to recognize some of the family members. And then you might have another sibling go, I don't know, but really 2 years ago at Christmas, remember? The point being, nobody can really identify. It's sort of like there was signs, there was some soft difficulties, and we kept saying, he's just getting older, he's a little forgetful. That's insidious, meaning nobody can say, this is when we noticed it. That's usually one of the warning things that we start to pay attention in thinking about Alzheimer's disease. We also start to recognize with Alzheimer's disease, it's consistently progressive. So the scary part about this condition is the brain could actually have disease anywhere from 2 to 10 years before we ever recognize it. And that's because our brain is a very complex forgiving organ. So a lot of damage can occur and the brain finds ways around it. So this area is damaged, the neurons start to try to communicate around that. Somebody will compensate. If they can't remember this, they'll do this. If they can't do this, they're going to find another way to express themselves. And we kind of write it off, and it's so subtle you don't really pay attention. But after about 10 years, 8 to 10 years really of this disease state, is when family members will begin to say, he's not remembering. He's getting lost in the car. By that time, this disease has had a very strong hold on the brain, which is why research today is really trying to focus on how can we identify this sooner? Are there biomarkers? Are there things at the neuron level that we can identify before a person starts to exhibit symptoms? Because that's really when we have our best shot at doing some treatment and some interventions. This is a good place for me to remind everybody that there are as I stand here today, there are really no great tests for us to say, aha, give them an MRI and we'll see it. Give them a CAT scan and we'll see it. Now, the research is kind of bubbling and moving in that direction of PET scans and starting to look at PET scans, and right now it's really in a research perspective, to see how glucose is managed in the brain, because there's some suspicion about that as being one of the early biomarkers, if you will, for Alzheimer's type disease. So stay tuned on that. There's still a lot of research being done, but right now the only way we can really make a definitive diagnosis is after a person has passed away and we do a post-mortem study of the brain. When you open the brain, you can actually see this disease. It looks like nothing else. Certainly some of the symptoms, again, for those of you who have worked with people with dementia, this doesn't come as any big surprise, but an impairment in short-term memory, inability to learn new information, judgment and reasoning is lost, language difficulties, so sometimes inverting words, trying to search for words, putting in appropriate words in sentences. You might find that they're socially more withdrawn because, again, to try to sit and communicate and be part of something social, when you have just enough insight and awareness that I'm embarrassing myself, it's kind of easy to go, yeah, I don't really want to go. I don't really want to do that. And we find them tending to isolate themselves in the early part of the disease state. Again, I'm not going to spend a lot of time on the pathophysiology of this disease because that's certainly well beyond what mid-afternoon with no coffee wants to what a conversation needs to be. But I do want you to walk away with having heard a couple of important words, which is really what's happening in the research arena of Alzheimer's disease. And that is the fact that what we've begun to understand is that there are these amyloid plaques. So if you think about your brain is like playing telephone. So if I whisper something to you, you whisper what I said to Regina, and Regina just sits there and doesn't share that. I forgot your first name. With Bevy, your cell might be very healthy, but you are never going to know what I said, not because you're an unhealthy, damaged cell, but because the chain of communication was broken between Regina and Bevy. What we know then is those neurons have to communicate with each other. The message goes, they communicate electrically and they communicate chemically with one another. When that is severed, that area of the brain no longer is part of the rest. Now, early in the disease, Regina's message is going to try to bypass Bevy. It's going to try to go around, and sometimes it will compensate early on. But the more damage that occurs, because of what we understand about a protein called tau protein, which exists in the brain, but the way it's supposed to exist is it builds itself up, then it dissipates through the brain. But for some reasons that we can't really completely identify yet, for some people that tau protein continues to build, and it creates these amyloid plaques. It's sort of like something that attaches to the end of the neuron and it strangles it. And you can actually see the neuron retreat and die. And so the more areas that happens, the more areas of the brain that are destroyed. I have a visual way of thinking about this. I think about it like a forest fire. If you've ever seen a forest fire from an aerial view, and you can just see the path of destruction that fire created, but yet along the sides of that path, you're going to see green trees and shrubs and healthy living organisms, right? So really the reality about Alzheimer's disease is where it spreads, it creates a path of destruction and it destroys the neurons. But where it goes and at what stage it goes is person specific. And that's why when you say, I've got this person with disease and I've got this person, and you go, but they look like two very different people. And it's probably why, up to this point I'm presenting science, but now I'm going to give you a bias. I'm not a big fan of staging Alzheimer's, where people will go, well, is my mom in the mild, moderate, advanced moderate, or end stages of the disease? Because from a care perspective, it doesn't change anything for me. Like, you might be in a moderate phase, but your behavior is such that you're quiet, you're confused, you sit over here. You might be in the mild to moderate, but it might be in the frontal lobe area where your behavior is very difficult to manage. And we make an assumption that the worse you get, the further along you must be. But in this disease, it really depends on what area of the brain is damaged, okay? Everybody with me so far? I know it's a lot of information, so slow me down or ask questions if you need to, all right? Okay, so vascular dementia is a little bit different. Well, it's actually a lot different. You ask a family member of somebody who has vascular disease and you say, when did your mom start having symptoms that you were worried about? You're going to usually, not always, but usually hear something like this. My mom went in for surgery and she never came out the same. My dad had a stroke, and after that stroke, his memory was bad, and then it consistently got worse over time. My mom's had diabetes her whole life, and then she would sometimes have these drops in her blood sugars and would have trouble getting her back to a baseline. And each time that happened, we noticed she was having more and more trouble with her memory. Usually with vascular dementia, you're going to hear a story like that. And what you're going to see from a progression standpoint is there's going to be an initial insult, whatever that is, stroke, cardiovascular event, and then they're going to, like stair steps, they're going to kind of level. They might function like that for a period of time. And then another event's going to occur. So they're still declining, but more like this as opposed to like this, which is how it is with Alzheimer's disease. So at least with vascular disease, while we're not going to change the total trajectory of the disease, we're going to still see decline. We do have the opportunity to say, manage your risk factors aggressively. Keep that blood sugar under control. Keep your blood pressure under control. Doing the things that take good care of your heart, that would take good care of your mind, to slow down or prevent the next insult, which would cause you to have more decline. Whereas with Alzheimer's disease, again, we don't know how to stop this. Once it starts, the ball is rolling downhill. And then that leads me to Lewy body dementia. This is one of those buggers where, imagine this. How many of you have worked with somebody with Parkinson's disease? Okay, describe those symptoms to me. Okay, what did she look like?
She was spacey a little bit,
Okay,
and then she would like say sporadic things in conversation and racism. That's what I saw.
okay. What other traditional symptoms do you think of with Parkinson's disease?
Shuffling gait.
Okay, so the gait is shuffling.
Tremors,
They've got tremors,
difficulty swallowing.
trouble swallowing. They always have kind of that masked look that people will say, she's just mean, or she looks so unhappy all the time. And the reality is with Parkinson's, it's affecting the muscles. So the muscles in the face, the muscles in the hands, there's a rigid quality that goes with Parkinson's disease. So put that in your mind. Think of somebody with Parkinson's, all right? Now think of somebody with Alzheimer's disease that I just described. And now think of somebody with a psychiatric illness where they're hallucinating, and they have paranoia, and they have delusions. And you put all of that together, and that's Lewy body disease. So they're some of our most difficult to take care of. The onset is usually pretty sudden. So somebody will say, wow, like all of a sudden we started noticing these changes. It can, what we call wax and wane. So you might say, this patient is really, like they're hallucinating, they're confused, he's falling, he doesn't seem to have good control over his motor skills. Somebody comes in the next day and goes, I don't have a clue what you're talking about or what you're smoking because this person looks fine, right? Because they do fluctuate and have this waxing and waning presentation, especially early on. The reason that I'm pointing Lewy body out to you is that oftentimes when somebody with dementia, whether it's Alzheimer's disease or vascular disease, we think about using antipsychotic medicines when they're hallucinating, when they have paranoia, when they have delusions, because they're not pleasant, and certainly we want to help them get rid of those. But medicines like the typical antipsychotics like Seroquel and Risperidone, while they might work great for people with vascular and Alzheimer's disease, if you give it to somebody with Lewy body's dementia, you're going to actually work the opposite. You're going to create more confusion, more agitation. You might even throw them into a psychotic episode. So this is where it's really important to make the right diagnosis, because all dementia should not be treated the same, okay? And lastly, I'm going to spend just a little brief period of time here on frontal lobe, because I know I'm throwing a lot of information at you. So the frontal part of our brain is the part of the brain that says to you, when you're thinking, I really want to tell my boss where to go, like I've really had enough, it's that frontal part of your brain that goes, oh, but remember, you got bills to pay. So it tells us when to be appropriate, when to manage that impulsive behavior. When the frontal lobe is damaged, either from disease or injury, Think about where the frontal part of the brain sits in the brain. Any trauma, this is where the concussions or traumatic brain injury occurs. When the brain is hit, when the head is hit, the skull is injured, the brain goes forward in the skull. So the area that takes the brunt of the hit is the frontal lobe. This is when you're going to start seeing people, and why I said post-concussion. We've got a lot of our professional athletes. And 2 years ago, I went to a conference at up in Boston at Harvard. Couldn't think of the name Harvard. See, it's on record now. I've got word finding difficulties. You know that school in Harvard, a school in Boston? And one of the things that they were studying, there's a scientist up there, and she actually takes the donation of bodies and brains of our professional athletes who there was some concern about changes in their behavior, and they've donated their brains to science. And she presented a slide of one of our athletes who everybody would know, very famous, who ended up becoming very aggressive, slapping and beating up his wife and his children, and he ultimately shot himself and killed himself. And he was 37 years old at the time of his death. They took a brain slicing of his brain and that of an 85-year-old who had advanced Alzheimer's disease, and the brain looked almost identical. And what the wife presented was, this was a very mild-mannered, loving person who had sustained many concussions through the course of his NFL career, who really, they didn't understand at the time, had so much damaged area of the frontal lobe. He became impulsive. He was gambling. He spent their money. He was making poor decisions. He had no control over his anger. He became aggressive, and then, as I said, ultimately ended up taking his own life. So that and other stories has shined a very bright spotlight on post-concussion syndrome. And fortunately, and I know that, I think in a very courageous way, Bernie Kosar locally here has come out speaking about his 15 concussions he sustained during the time he played here for the Cleveland Browns. Yeah. And I think, again, very courageous, because when he first came back to Cleveland, people would hear him on the radio, and he's an incredibly bright man. And everybody was saying, oh my God, he's got to be drunk or stoned, or he sounds like a woman, or what's happening to him? He took a lot of criticism until he came out very honestly by saying he has really essentially no short-term memory. His language center of the brain was really interfered with, which created some changes in his vocalizations. And again, it was another reminder that in the day, we used to say to an athlete, you okay? How many fingers do I have up? You're good to go. And most of these athletes would say, I don't even remember them asking me about how many fingers. I was just nodding, and out they would go. And Bernie, by his own admission, would say he just carried smelling salts. And so he would pull it out and bring himself around, and many of the games doesn't even really remember playing. And we know now about post-concussion syndrome that leads to frontal lobe dementia. If you have an injury in a short window of time before the brain can heal, it causes permanent damage, which is why now we're looking at forget about our athletes at the professional level, our college athletes, our high school athletes. We're starting to really pay attention to those peewee leagues to say, are the helmets designed properly? Are we making sure that we have good protocols on the sidelines for our physicians to be saying, you take one injury that we think could be a concussion, you're out for the game, or maybe out for several games. So again, because of all of that, we're starting to see this real resurgence of the concept of frontal lobe dementia. So I just wanted to point it out because we do see that. You can have frontal lobe damage related to your Alzheimer's disease as well, because of course if the disease spreads there, you're going to get very similar kinds of symptoms. But I just wanted to make sure that you had heard that, you knew something about it, and we're going to talk a little bit more about frontal lobe as we go through.
What do you mean by executive function?
Okay, so executive function is our higher level thinking. So it would be like if I were asking you questions and I said, can you tell me what 2 + 2 is? So that's lower thinking, right? You can tell me what that is. If I ask you to extrapolate from that and say, okay, if there are 2 boxes here and 2 boxes here, and we really need to get to 10 boxes, you've got to strategize. You have to think about, well, that's 4, then it's 6. So the more complex the thinking is really your executive level functioning. And that really all sits in the frontal lobe of the brain. And we see that more with higher species. So, like our apes have pretty good, well-developed frontal lobes, more similar to humans, which is why they're able to learn strategies, problem solve, versus lower creatures where the frontal lobe is smaller, other areas of the brain more instinctively are bigger. So the executive functioning really looks at that higher level of problem solving and thinking. People who have frontal lobe damage, whether it's from frontal lobe dementia or Alzheimer's that has spread, you are going to see more sexual acting out, more impulse control that's not there. These are the people who are going to blurt out whatever they're thinking or whatever they want to do. It's going to happen right here, right now. Which again creates, on a unit, creates much more difficulties in terms of managing.